Hello, good morning everybody. I think we might get started. I'd like to welcome you to Workshop 28, which is Clinical Genetics and Beyond. My name is Ed McCone. I'm an adult CF doctor based in Dublin, Ireland. And my co-chair is Karen Rory, who's a genetic counsellor based at Johns Hopkins and coordinator of CFTR2. Unlike a lot of the workshops, we have a slightly hybrid structure to this particular session. We have three fantastic speakers who will be presenting some of their research. And we thought it would be interesting to also have a debate at the end about the use of CFTR correctors in patients who have not quite CF, or maybe an unknown mutation or sweat chloride is not quite classically above 60. So I'm very fortunate to have Scott Bell and Michael Shensky who will debate at the end. I just want to let you know that there's actually a change in the program in that Michael will go first as a pro and Scott will go second as a con, and then there'll be a couple of minutes for rebuttal at the end. Just also let you know that if you might just use your apps to enter any questions you might have for the end. We'll be asking questions of each speaker after they've finished, and then at the end of the debate we'll obviously have a few questions for the speakers, and perhaps we'll have some discussion as well from the audience. So we'll go ahead and start, and I'd like to introduce our first speaker, who's Eleanor Langfelder-Schwind, who's based at Lenox Hill Hospital in Northwell Health. And she's going to present her abstract, Variable Genetic Counselling Access and Services for Parents of Infants who Screen Positive for CF in New York State. So thank you, Eleanor.
Slides. Good morning, everybody. So first, thank you very much to the organizers for inviting me to present the work of the New York State CF Newborn Screening Consortium as part of this terrific panel. I have no disclosures as part of this presentation, but I do receive some grant funding from both CFF and Vertex. So the Cystic Fibrosis Foundation has recently endorsed guidelines recommending genetic counseling by a provider trained in genetics and with expertise in CF for all families of infants with a positive CF newborn screening result. The CFF patient registry asks if parents of children under 2 have received genetic counseling. I'm grateful to the registry for providing me with this data. For babies born between 2018 and 2020, the range was about 45 to 50% answered yes, but the genetic counseling provider is not specified. And data is missing or unknown for a large number of children, and that data was not included in the denominator. The training of a genetic counselor generally includes a 2-year master's degree program that's accredited by the ACGC, and there are more than 4,500 certified and or licensed genetic counselors in the United States via the American Board of Genetic Counseling. Now, genetic counselors are not yet recognized by the U.S. Centers for Medicare and Medicaid as independent providers, and we are not currently on the list of required or recommended CFF care team members. It will literally take an act of Congress to get onto that Centers for Medicare and Medicaid list, and it will take an act of the CFF Center Committee to become a recognized or recommended CFF care team member. We'll see which happens first. So Rich Parad and Karen Rary and I did some work in 2018-19 to survey genetic counselors and CF care centers to learn more about engagement between genetic counselors and CF care providers. And we found kind of 3 groups of genetic counselor, CF care center relationships. Genetic counselors can be engaged and embedded in a CF care center, and about 22%, less than a quarter, fit that category. About 39-40% of CF care centers refer positive infants with a positive CF newborn screen to genetic counselors, but they aren't typically involved in CF care in the CF center. And then another about 39-40% were not engaged at all with pediatric CF care centers and the newborn screen diagnostic resolution process. But this project today focuses on the New York State newborn screening consortium, and our algorithm has evolved quite a bit over the last 20 years since an IRT DNA algorithm was instituted in October of 2002. Today, we use a 3-tier IRT DNA sequencing algorithm, and that is as of December 2017. We use a floating cutoff. There was a lot of discussion in the newborn screening meeting this week about fixed versus floating, so I assure you we are floating. And a CFTR variant panel, which has increased from initially 39 to currently 369 variants, and that's based on CFTR2. Infants with 2 CFTR variants are referred for sweat testing at one of 10 specialty care centers, or SCCs, as I'll refer to them in my slides. Infants with 1 variant or a very high IRT category, that top 1.1%, will undergo 3rd-tier sequencing of the CFTR gene. We do use a very high IRT category as well because our data showed that we would have missed particularly Hispanic infants if we eliminated that category. So we have agreed as a group to keep that in. It's an important way to address health equity. So infants with 2 or more CFTR variants of what I'll call potential clinical relevance, or perhaps what Denise Kay at our state lab calls potential clinical relevance. We have a lot of terms that we use. They are referred to the local specialty care center for evaluation. And we're really fortunate in New York that the state lab offers parental testing to phase the familial variants. We can draw blood, put it on a Guthrie card, and send it up to the Department of Health. Infants whose variants are found to be in CIS are discharged as CFTR carriers, and parents and the primary care physician of infants with 1 CFTR variant are notified by mail. They are not considered a referral. And genetic counseling is recommended for all of these different categories. So for the current study, the New York State Department of Health requested demographic and clinical data from each of those specialty care centers for babies that were referred between the start of the sequencing tier and the end of November 2020, so the first 3 years of that sequencing tier. And there's 60 different variables that were requested, and we are really grateful to all the coordinators who filled out a very, very large spreadsheet. My talk right now will focus on 4 of them: CFTR genotype, phasing, and whether or not the family was seen by a genetic counselor, and if not, why not? And if you'd like to learn more about the rest of the variables, I invite you to Kathy Kier's rapid fire presentation 11, which is happening later this afternoon. So infants referred for CF screen positive inconclusive diagnosis or CFTR-related metabolic syndrome, CF-SPID, CRMS evaluation were included in this descriptive study. And those were infants with elevated IRT and more than 1 CFTR variant, and with 1 or more of those variants being of uncertain significance or varying clinical consequences defined by CFTR2, VUS as defined by ACMG criteria. And then infants classified as having CF were excluded from this particular analysis. Genotypes and CFTR phasing data were abstracted from the newborn screening records or obtained from the specialty care clinical data. And the Department of Health IRB determined that this project met criteria for a non-research public health evaluation. So 290 infants met study criteria, and 94.1% were evaluated at least 1 time, either at a specialty care center or a sweat chloride test was done and submitted to the Department of Health. 71% of those had parental phasing of at least 1 parent, and 32 infants had all of their CFTR variants confirmed to be in CIS, either by parental phasing of at least 1 parent or predicted to be likely in CIS based on population data, and I'll tell you a little bit more about that in a minute. 16 infants had 1 variant reclassified either as non-CF causing through CFTR2 analysis or as benign or likely benign based on ACMG criteria, which leaves us with 225 infants classified as having CRMS CF-SPID. So these are the variants that were found to be in CIS. Some of them are well known to this group, the R117H5T, and less commonly known, probably F508del with L467F, but this is a pretty sophisticated crowd, so it may be familiar, and then the R74WD1270N. And the 4 babies I mentioned whose variants were reclassified as likely, let's see, how do I get a pointer? Hang on. Sorry, I should have asked that earlier. Oh, this.
Yes. Got it.
The picture of the pointer is a pointer. Okay, all that good genetic counseling training has served me well. So, as I mentioned, so the 4 babies who were reclassified as likely in CIS, 3 of them were L467F508del, and 1 was R74WD1270N. And the rest of these variants are quite rare. I could find only 2 of them after pretty extensive literature search and searching the usual databases, the CF mutation database, CFTR2, CFTR France. So it remains to be seen how common they turn out to be. And 5 variants in the data set were reclassified as non-CF causing as likely benign, according to ACMG criteria, and these or non-CF causing in CFTR2. And these variants that are identified after reclassification are actually no longer considered actionable by the Department of Health. So with all of this complicated genetic information being generated by the newborn screening program, we wanted to know who was talking to these families, what were families able to learn from genetics providers or other providers. And we learned that 35% of families were seen by a genetic counselor. 51% of families did not see a genetic counselor, and for 14%, it was either marked as unknown or left blank. And so for the families the 51% of families who did not see a genetic counselor, we did give centers the opportunity to write in a comment about why not. So that data is on the next slide. And for 79 patients, we were able to collect data about why they did not see a genetic counselor as part of their newborn screening follow-up. And the most common reason was that a physician provided the genetic counseling. The next most common was that a genetic counselor was not available at 19%. We do have a number of families who decline genetic counseling. It is not a mandate. It's mandated to offer it, but it is not mandated to accept it. In a couple of cases, there was a known family history, and that was what the CF Care Center provided as a reason for why genetic counseling was not provided at this session. And for 2 patients, the infant was adopted or in foster care. So we realized that physicians are providing genetic counseling. They are not genetic counselors. So we wanted to kind of compile all of that data and really take a look at how many families were getting genetic counseling and then who was providing those services. So ultimately, 35% of families received genetic counseling from a genetic counselor. Overall, 20% received genetic counseling from a CF physician. 31% no genetic counseling was provided at all, and again, the 14% where it was either unknown or the data not reported. So in conclusion of this study, genetic counseling is provided inconsistently to parents of CF newborn screen positive infants in New York State. These are kind of similar findings to the national data from the CFFPR. Additional efforts are needed to ensure equal access to genetic counseling services across CF care centers, and we think improving data collection and tracking will help to further define the scope of these solutions. CFTR phasing is essential to the confirmation of CRMS versus CF carrier status. It makes a big difference to a family and I think we'll hear a lot about that at today's session. And then reclassification of variants leads to counseling challenges and highlights the need to maintain rapport with families over time. And then I do have a few minutes left, right? Okay, it's so good, because I have a case that I'd like to just kind of go through that really highlights some of these challenges. So baby boy was referred to us shortly after the algorithm change with an IRT of 70, which was in the top 5th percentile for a floating cutoff. and was found to have F508del and R170H. Now, not to be confused with R117H, which is a whole different talk and a whole different session. R170H is a missense variant in exon 5. It's a substitution of histidine for arginine. And research shows that it's actually more involved in impairment of bicarbonate transport, and chloride transport can be normal with this variant. And determinations of its clinical significance and pathogenicity have been variable. In ClinVar, there are conflicting interpretations, including uncertain significance and likely benign. CFTR France has 12 patients with CFTR-related disorders, predominantly CBAVD or pancreatitis. And CFTR2's original call was indeterminate, and then it became non-CF causing. And just as relevant to our later panel and the debate that we're going to see, it is FDA approved for treatment with CFTR modulators. So our patient actually was informed the parents were informed of the positive newborn screening result by the pediatrician, who put us immediately on conference call because the family was confused, but there was kind of an edge to that confusion which needed to be explored and unpacked in a different way. They just could not believe that their child had 2 CFTR variants. And so what we learned was that their older child had had a positive CF newborn screening in the prior algorithm with 1 copy of F508del, had a normal sweat chloride, and was discharged as a CF carrier. The parents had carrier screening. Dad was found to have the F508del, and mom was negative. They actually researched how to get better genetic testing, I guess I'll say. The mom was negative on a panel, and they found a direct-to-consumer company that did home-based testing for about 200 genetic conditions using next-gen sequencing, and they felt like they were very highly reassured that mom was truly not a carrier. But it turned out when we called the lab and unmasked the variants of unknown significance that mom actually did carry R170H. It's very typical for laboratories not to report variants of uncertain significance on a prenatal screening report. So once we kind of were able to lay out what happened, the parents expressed a lot of understanding. Still a little frustrated, I guess, that they had taken these extra steps to have what they thought was which was really top of the line genetic testing, but they still ended up with a surprise in their newborn. In terms of the baby, he was well. He was examined by our CF center director, and he had a sweat chloride, which was in the normal range, less than 20 millimoles per liter. And he was given a diagnosis of CF SPID CRMS. And we talked to the family about what that means. We talked about the likelihood of developing CFTR-related conditions, pancreatitis. They had also done some research. They knew about male infertility. They actually had friends who had gone through IVF, and while they were a little bit, expressed some sadness that their child might be infertile, they were relieved to know that there was an assisted reproductive technology and he could have children, and that was not something that they had to worry about, and they were kind of comfortable with knowing that. As I mentioned earlier, CFTR2 removed R170H from their panel, and so the question is, what do we do with this little boy? Do we continue to follow him or not? We spoke with the parents, and he was ultimately discharged from follow-up at risk for CFTR-related disorders, but knowing that they could always come back to us if they had any questions or concerns, and to kind of use their pediatrician as their primary source of evaluation. But they informed us that they were expecting baby number 3. So they had already made the decision. I guess it's clear. We recontacted them after the variant was reclassified. And they had made the decision not to have any prenatal testing for the 2 variants. They were comfortable just going forward with the pregnancy, but they didn't want a surprise at the newborn screening. So they wanted to plan it out. I talked to them about, do we want to contact the state? Do we want any special testing? And they really didn't. And they were, again, kind of confused, but with less of an edge this time, that this time, if the baby had an elevated IRT and 1 delta F5 weight, they would get a letter in the mail with no report on the R170H. So luckily for us, they have very high health literacy. They have access to a lot of resources. They were very comfortable coming back to us with questions or concerns. And we made a plan that we were here and available to them if they needed us. So right now, the baby's status is unknown. As far as I know, the baby did not have a positive newborn screen. Parents did not get a letter, but they know where to find us if they need us. So clearly, newborn screening programs generate complex genetic information that requires interpretation and counseling about its implications. These challenges aren't unique to IRT DNA sequencing algorithms, but they certainly add a layer of excitement and complexity. And as more states implement third-tier sequencing and countries implement third-tier sequencing, these challenges will be compounded potentially by lack of access to knowledgeable genetics providers. So with that, I will stop and take questions.
Thank you, Eleanor. And just a reminder, people can use your NACFC app to send questions. I'll start with actually just a logistics question. Can you talk a little bit about how the phasing is done in your program? Because I know that we have anecdotally heard from providers that not every center likes to order genetic testing on people who are not their patients. So how does that work in your process?
So we are really lucky in New York because we can draw blood on the parents and put it on a Guthrie card and send the Guthrie card to the state. There's an informed consent process, so it was a little surprising to see how many centers reported that they don't provide genetic counseling when the family has to sign a consent document. So I think we have to kind of dive a little deeper into that process and what's really going on in those conversations. But otherwise, the blood spots dry and they get sent back to the state. We haven't had an issue. I'm sure there's at least 7 or 8 of the consortium here. I don't think there's been any issue getting those drawn and sending them to the state. They just go with the regular newborn screening cards.
I don't see any questions, but if anybody feels brave and wants to shout a question out, please do. My question is related to the delivery of genetic counselling. And I suppose over the course of the pandemic, we saw, for example, psychological counselling was able to be delivered online using Zoom and Microsoft Teams and so forth, and was quite effective. And I'm just wondering if, in the absence of genetic counsellors in a lot of centres, is that an option that could be delivered remotely?
I'm glad you asked. So I've been providing genetic counseling via telehealth really through the whole pandemic. Pretty much if we didn't have to put hands on the patient, we could talk to them over telehealth. And actually my grant that I disclosed at the beginning of the session is actually to do a stakeholder assessment and look at CF-specific genetic counseling via telehealth. One of the things we found in our earlier study was that the CF centers that weren't engaged with a genetic counselor, a lot of them didn't think the genetic counselor knew enough about CF to sort of trust them with their patients. So we know that on the flip side, when the centers have an embedded genetic counselor, it's gold stars all the way. So that making sure that the counselor that's providing the CF-specific genetic counseling really knows what he or she's doing is really critical.
And I think just a related question really is about the knowledge of the provider, because obviously that's the person who's also giving this information. I'm just wondering how confident you would be that the provider is able to provide the information to the patient, and whether we should be standardizing training for providers in the absence of a counselor.
I think it's a great idea to standardize the training because a genetic counselor isn't always available at the time that it's needed. Some patients, as we know, come in very anxious and they have a lot of questions. And if the genetic counselor's not right there to answer them, you can't say, oh, someone will call you or make an appointment that you can, in 2 weeks. Excuse me. So it is having these conversations excuse me, with providers so that they understand what all the components of a genetic counseling session is pretty important too. Thank you.
I'm going to have you just answer one quick question because a couple of people asked it. It's a yes, no. So was the first child in your example tested for the R170H after the fact?
She was not. Again, we offered it, and at the time, it would have been simple to ask the state because it was still on, they were still reporting it, but they really just, they did their best to be information seekers, and I think they felt like it was time to pull back and just enjoy their healthy children.
Okay. Thank you.
Thank you.
See if I can get us out of here. So I am very pleased to introduce our next speaker as Eileen Barr, who is a genetic counselor at Emory University and with the Children's Healthcare of Atlanta, and she's going to talk to us about initiation of standardized care pathway for individuals with CRMS and their clinic at a large CF center.
Okay. All right. Hi, everyone. Thank you so much for inviting me to talk today. And as Karen mentioned, we will be discussing our standardized care pathway that we created at our CF Center and initiation of a CRMS clinic. I have no disclosures. And basically, we'll start off with an overview of the current guidelines for CRMS management and care, review the preferences and practices from the providers at our center, discuss how we implemented the plan for a standardized care pathway for these patients, and provide insight on development and launch of our CRMS clinic. It's a great transition from Eleanor's talk. So, for some background, the main guidelines that we referenced in our discussion and review was the 2009 CF Foundation guidelines for the CRMS diagnostic workup. And really what precipitated this discussion was the updated guidance that came from Barbin et al. In September of 2021 in the Journal of CF. And so basically this updated guideline reviewed previous publications as well as retrospective, prospective, and registry studies. And some of the recommendations differed. And so what do we do? So we talked about these two, comparing the two guidelines and decided what was going to be our standard pathway moving forward. Mainly, there was some changes to the timing of sweat chloride, recommendations for continued review of CFTR variants. Eleanor's example is the perfect one. There's changes in classifications, and we need to keep up to date with those. Fecal elastase recommended additionally at 12 months old, as well as adding on chest imaging at 6 years old, with the recommendation that this care be provided by someone who's familiar with CF and can monitor for any symptoms that might develop over time. So this is an image from the 2009 guidelines, and you can see a lot of the initial workup is at the time of diagnosis, sweat testing, fecal elastase, and notably that a respiratory culture is recommended at every subsequent appointment and annually after that. In the updated guidelines, you can see that the sweat chloride recommendation was added on for 2 years and 6 years, fecal elastase at 12 months old, and then the change in respiratory culture recommendation could be considered, but not necessarily recommended or required. And then additionally, this chest imaging at 6 years old. And just a little plug, genetic counseling also recommended. So from our standpoint, a local background on our clinic, one of our biggest concerns is that overall patients with CRMS are healthy and do really well, and eventually over time they get lost to follow-up. We had that as a big issue in our clinic. We also had the concern that potentially their genotypes weren't being consistently reviewed for variant reclassification. And mainly that's because our patients with CRMS were being seen at varying settings. So some of our patients with CRMS were being seen at the general pulm clinic with their pulmonologist, and some were being seen at the CF center. So at the CF center, you have access to throat cultures, labs, any kind of other thing, anyone else from the CF care team that they may need to see. and genetic counseling where I can review the updated variants. If they're being seen in general pulm, there may not be those access, notably for the throat cultures. And then the possibility of enrolling in research and registry. There was an overall desire from our center for a CRMS clinic and being able to provide more active population management for these individuals. So what we did was I created a nice short multiple choice survey that I got sent out to all the providers to learn about their preferences and practices. And we focused on the workup from initial management, comfort with development of a CRMS clinic, and recommendations for our standard care pathway moving forward. Our first question was, are you comfortable with a CRMS clinic and will you refer your patients to us? And thankfully mostly everyone said yes. So we were able to move forward with that. And then the next question that created some interesting discussion was, at what time do we refer to the CRMS clinic? Is it at the time of initial diagnosis? But then over those first few months and the first few years, you have a couple additional recommendations for sweat chlorides, fecal elastase, things like that needs to be cared for more frequently than a potential annual follow-up CRMS clinic. So ultimately we decided after the repeat sweat test at 2 years old and all that initial workup being completed, at that point that would be most appropriate to come to see us in our CRMS clinic. Then came the question of the throat cultures, which, similar to the guidelines being differing, so did our providers. We were split at 50-50 on that one. And there was really an interesting discussion here as well. There's the concern of over-medicalizing patients with CRMS. Do we just do a throat culture if they're symptomatic? And so eventually, after the discussion took place, we talked about how the CRMS clinic would be a part of the CF Center. We have access to throat cultures. The CF Foundation guidelines recommending throat cultures, and with 50% of our providers wanting or thinking this was what we should be doing, we went with recommending that for our annual CRMS clinic. Patients with CRMS can have other respiratory concerns unrelated. So what about the patients who are being cared for by by their pulmonologist for asthma or other respiratory diagnoses? They're already going to be seeing their pulmonologist, so they then also need to see us in CRMS clinic annually. And the majority did feel like it was still important for us to have that annual CRMS clinic to focus more on that, the variant updates, and those other workups we discussed already. And then the question of transition. So at what age is it appropriate to move from annual to PRN or as needed? And there was another bit of a split decision here. Some people felt that it was appropriate that after the age of 6, when you had that repeat the chest CT and repeat sweat test, after that point, is it okay to go PRN? But then there was more of the majority felt like at an older age. We talked about the concern about loss to follow-up. So we wanted to be able to have that consistent annual follow-up to manage, monitor, and meet with these families. But then there's the important discussion of reproductive counseling. So in our clinic, I like to meet with individuals with CF around 14 to 16 to sort of have that genetic counseling appointment again for them that their parents had when they were younger. Talk about their genetics, talk about their diagnosis. So for CRMS, this is why we've been following you over these years. These are things that you might want to look out for as you get older. And then the discussion about recommendations for carrier testing and their partner in the future. Depending on their genotype, they may have a chance of having a child with CRMS or classic CF if their partner is a carrier. And then also the discussion around CBAVD, which we know is a risk for males with CRMS as well. So ultimately, felt like the older age group was more appropriate. Going into adulthood would be the time we would transition them. So we discussed all these. We had a really great meeting at a monthly QI session and met with all of the CF care centers so we could sort of get the input from all the stakeholders and develop the care pathway. So we made a nice flow chart so that everyone can follow. Standard workup, this is for after the time of diagnosis to the 2-year transition to CRMS clinic. We wanted to make sure that all of the providers were still consistently following these recommendations at the timelines that we developed, with certain things being left to their discretion, like the throat cultures in that first 2-year timeline, as well as any imaging or labs they might want to recommend. We included the repeat sweat test at 2 years old, the fecal elastase at 12 months old. And then the one thing we did note at the bottom was this question of the concern that if there was a possibility that your patient may seem higher risk to you, that they may be showing signs or symptoms related to CF, that they may convert from CRMS to CF if their sweat trended up in that 2-year repeat. Probably keep them. Don't send them to our CRMS clinic. But mostly that's because we didn't want to have them transition to us and then convert and have to go back to that provider. So those were the ones that we sort of had an asterisk next to. And so for CRMS clinic, basically this is the consensus we developed after 2 years when they start to come to follow with us in the CRMS clinic. It's run by our nurse practitioners and myself. We also have RT there and other individuals from the CF care center, like social work, a dietitian if needed. But basically, we're just monitoring for symptoms. They'll have their annual PFT and throat swab. We'll repeat the sweat chloride at 6, chest CT at 6, transition from our care at 18. We had our first clinic was a success. We had it in October. And the goal is to have currently twice a year about 16 patients. As we continue to grow and identify more patients, there may be potential for more than 2 a year. But there's challenges as well. So I just wanted to mention that we did have a few challenges. Most notably, some parents had been following with their provider for a really long time and didn't want to switch. They wanted to have that discussion with their provider first. And so the really important thing that we identified was that this conversation needed to come from the clinical team. We couldn't just have the scheduling team call them up and say, hey, you have to come to CRMS clinic. So the nurse practitioners, myself, and some of the providers as well reached out to the patients we identified as good potential patients for our first clinic. And we had that recommendation. And families were quite receptive to it once they had the conversation. Yes, so that was our CRMS clinic and our care pathway. And a special thanks to my team and our nurse practitioners who helped me do this.
Thank you, Eileen.
Thank you.
We do have a couple questions coming in here, so we'll start in the app and then can go out to the audience. How do you plan to handle scheduling conflicts by only holding a clinic twice a year?
Scheduling conflicts in what sense? Yeah. Mm-hmm.
Can you, Eileen, will you repeat the question? Because I think this is being recorded.
The question is if right now, if we just have it twice a year and patients cancel and then they need to be rescheduled, they won't be booked for another 6 months out. And then, it's one date, that's really it. We do not know what we'll do for those. Right now we're just going to see really about seeing how many patients we can get on the schedule, seeing if that is an issue. And then making a plan, I guess, after that. I will.
All right, so a couple more.
Thanks very much for a great presentation. So 2 questions. Where are you transitioning these patients to? Because the adult services are going to get bigger and bigger and bigger over time. And who's going to follow these patients up? And the second question is, why is CT a situation based? Because these are relatively asymptomatic patients who have minimal disease.
Somebody else asked that too.
Okay, I'll repeat the questions. First question, where are we transitioning these patients to after 18 years old? The adult clinics are just going to keep getting larger and larger. And that's a really good question, one that I was thinking about myself a lot recently. We haven't gotten to the point yet where the CRMS patients are transitioning to adult care. That's going to be something that will have to be addressed. The question of if at some point do they need to be converted to CFTR related if they have any symptom, or, let go, just PRN if anything were to develop. That's a really good question. I think our plan would be to work with our adult care team on what we want to do for the provider consensus for our CRMS patients in the adult care, and probably be PRN, educating in that transition time frame to the patients, like these are things to look for, and to come back and see us if anything developed. And then the second question, CT, yes, there is some literature out that shows that you can have changes on imaging without outward symptoms in these CRMS patients. So I believe that is where the recommendation came from. But one thing I forgot to mention is that there are some updated CFF guidelines in the works from CRMS soon to come, and hopefully we can get some more insight from that as well. Yeah.
I have a quick question for you. I'm just curious about the family's view of this. Have you interviewed the parents and asked them the same questions you asked the providers in terms of when they would like to move to a CF center versus staying with their provider?
I really like that idea. I think that one of the things we were thinking about after our initial clinic was to survey the families and see how they felt. The families were really excited after talking. Some of them were older, 6 or 7 years old. The family, wanted to rediscuss the genetics from that time before, wanted to understand a little bit more about the potential conversion to CF if they were to ever start to develop symptoms. So I like that idea. I would definitely consider, asking the families what their interests are in that.
Thank you for the presentation. I just had a comment. I wouldn't call these people patients.
Mm-hmm.
They're healthy people.
You're right.
Can we prove that something is wrong with not patients?
The comment was that I should not refer to the CRMS individuals as patients. They are healthy people who have not showed outward signs of symptoms at this point, so thank you for the feedback.
Very, very nice presentation. In coming up with those flow sheet, do you look at your significance of fecal elastase or throat culture to come up with that flow sheet? Like how did the stool elastase help in your flow? That's what we're trying to do in New York, to look to see any of these help in our work, and possibly even eliminate stool elastase.
That's a good question. The question was if we took a look at the workup in our flow chart and saw if there was benefit to doing the fecal elastase at 12 months old. Mostly we were following that. I think it's interesting, the CF Foundation guidelines recommend it as needed. So if someone shows symptoms, with the updated guidelines from 2021 saying that it should be repeated at 12 months old. I think it's a good debate and one that we discussed. You would expect the patient to be having weight issues or GI issues, and the symptoms can kind of tell you. But no, I did not look back and review the fecal elastase data.
I just might make a comment on that because I suppose it's a lot of discussion within the registries regarding CF SPID and CRMS. And I think the important thing is to collect as much data as we can initially and then study it and see whether we need to be collecting it. And I think that's probably the goal of the next few years as we get more and more patients with these diagnoses to see whether we can cut out some of these early tests that are done.
Absolutely.
Maybe related to that, I'll tie in one of the questions here. Are you entering these individuals that are in your CRMS clinic into the registry, into the CFF patient registry, so that we can have a nice repository for all this data? And see
that was one of the motivations behind
Great.
getting
Maybe
everyone into
mention
the CF Center.
That's great.
Okay, any other questions?
There's actually many more in the app.
I
still.
saw, I was like, oh God, let me get
Maybe
out
I'll
of
just
here.
ask a quick one because this is, well, we won't have time to go through all of them, but are these visits being covered by insurance?
Yes.
Well, that's nice to know. Okay.
I mean, it happened in October, so I haven't gotten an angry phone call yet.
Well, great. On that note, I think I'd like to thank you for a great talk there. Well done. Well done. So it's my pleasure to introduce my co-chair as our next speaker, Karen Rory, who's a genetic counselor. She's also coordinator of CFTR2 at Johns Hopkins University. And Karen's going to talk about my patient has an unresolved CFTR genotype. What next?
If I can get this going, we'll get in here. There we go. Well, good morning. Thank you to everybody for coming for a Saturday morning session to just talk about your favorite topic, really tough patients. So I'm going to present, get situated up here. I'm going to present the work of a larger group from the CF Genome Project here. This is an abstract presentation of poster number 152. At least I'm going to try to. Everybody else figured this out. These are my disclosures. So I promise this is the only review type slide that's really obvious. But I'll just remind us all that CF is a recessive condition and it's caused by 2 pathogenic or disease-causing variants in CFTR. And of course, one variant is inherited from each parent. And with advances in genetic testing technology, today we typically can identify both variants. We're actually pretty good at doing that. And we do that by genetic testing. And there are several types of genetic testing that I'm sure many of us are familiar with and which have evolved over the years. And while I think that most of us are pretty familiar and comfortable with these, I'm just going to review some of them in the next few slides to make sure that we are all on the same page when we talk about new technologies. So first we have basic variant panels that look for a limited number of CF-causing variants. And so this test will only detect the variants that are on the panel. If your patient has a variant not on the panel, it won't pick it up. These variant panels come in several different sizes. The most basic is typically the 23 ACMG, which is going up soon. But there are also expanded panels that go up to 97 variants or 139 or maybe even more than that. Beyond that is what I'm going to call for this talk typical clinical sequencing, which looks at the coding region or the exons of the CFTR gene plus a tiny bit of the non-coding region. And thanks to our excellent plenary speakers, I know you are all experts now in understanding the difference between exons and introns. So you know that the exons are the portions of the gene that get translated into CFTR protein. And these regions are always covered by typical clinical sequencing. Intronic DNA, also called the non-coding region or the intervening sequence or IVS, this gets spliced out and is not part of the final protein product. Just a tiny little bit of the intron, the sequence that flanks or sits right next to the exon, gets included in typical clinical sequencing. And this type of testing usually also targets a few what we call deep intronic variants that sit kind of in the middle of that non-coding DNA, but the rest of the intron is pretty much untouched in this type of testing. And so if you want to get to the rest of the intron, you need a newer type of technology, full gene sequencing. And this includes all of the coding region and the non-coding regions. And while we normally look at this nice cartoon of the CFTR gene that's got the exons in the red boxes and the introns and the lines connecting them, it really fails to show you the true scale of the difference in size of these regions. And so if we look at a more to-scale image, you can see that the introns vastly outnumber the exons by way of number of base pairs. And it turns out that actually the coding nucleotides that are looked at by typical clinical sequencing only make up just a tiny fraction of the entire DNA sequence of the CFTR gene. I'll also mention here that deletion and duplication analysis, or del-dup testing, is frequently performed both with this type of full gene sequencing, but also typical clinical sequencing. And del-dup analysis looks at various methods of looking for large, extra, or missing pieces of DNA, usually 1 exon or more. So now that we've laid out what we're talking about here, I'm going to get into our study. So we had 2 parts, a retrospective look at the utility of full gene sequencing, and then a prospective look. So let's dive into part 1. This was work of the CF Genome Project, which involves a cohort of over 5,000 individuals with CF that were recruited to CF-specific studies by 3 main institutions. So these patients come from all over the US, a handful from outside the US, and they have mostly white European ancestry. So for this cohort, the Broad Institute performed whole genome sequencing, or WGS, which looks at the entire coding and non-coding region of all the genes, including CFTR. Then we did a deep dive into the CFTR gene sequencing, and also 866 other genes that have some relationship either to CF by way of phenotypic overlap or CFTR, interactions, interactome, pathways, et cetera. We also did a retrospective review of clinical data in the CFF patient registry and in chart-extracted clinical data for some patients. And our question in all of this is, amongst individuals who have CF and who have now had whole genome sequencing, how many are really left without a genetic diagnosis of CF following that testing? So we had 3 phases of analysis. First, we separated out the people who had 2 disease-causing variants that we could easily identify in the coding or flanking region and by deletion and duplication analysis. Essentially, typical clinical sequencing. How many could we solve genetically just by that alone? And the answer is about 99%, so almost everybody, essentially. So the findings in this group are described in a paper from earlier this year, and I'm not going to talk about them anymore in this study today. What we are left with are these 2 other groups. So we have 35 individuals with 1 identified disease-causing variant, and then 14 people who have no CF-causing variants in CFTR that were identified in phase 1. And that makes up just 1% of our cohort. So next, we looked very hard at the non-coding regions of CFTR to see if there was anything in there that might explain CF disease in these groups. We also looked carefully at those 866 other genes that I mentioned. And out of these 49 individuals, we found 2 that had an additional variant in the non-coding region. And I will say it's almost cheating to call it 2 people because they're siblings, so it's the same finding. So call it 1, call it 2, a small number. And unfortunately, no additional variants were found that could fully explain somebody's disease in the remaining 47 of 49 individuals. And that was surprising to us, a little disappointing, I might add. So then we decided to go back and, as much as we could, try to really carefully check the phenotypes of all of these people and the reported genotypes to the patient registry and see if we could figure anything out. And so in 6 people, including the 2 that had had this additional variant identified, those 2 siblings, we were able to confirm a CF phenotype, at least based on the clinical data available to us. High sweat chlorides, evidence of either pancreatic insufficiency, lung disease, et cetera. But in the remaining 43, we couldn't confirm their CF phenotype, and in some cases, we actually think we ruled it out. So I want to discuss this group because we were surprised at the sheer number of them. And you can see listed to the right are the number included for each of these reasons that we couldn't confirm CF. And you'll see my numbers to the right don't add up to 100, they add up to more than 100. Some people fell into multiple categories. So over half of this group did indeed have 2 variants that were reported to the CFF patient registry, but at least one of them had been deemed non-CF causing in somewhat recent years. And our thought was that at the time that these patients were recruited, and some of them were recruited 20 years ago, at the time, it's entirely possible that somebody really did think that their genotype was fully CF causing. And so we kind of ruled them out as, well, we're not sure these actually have CF now, but maybe somebody along the way thought that they did. For about a quarter, additional clinical data that we were able to look at was just not consistent with CF. So when we looked at additional sweat chloride data available to us, some of it was either non-diagnostic or in the normal range. And then about the same number of people had not been seen at a CF center for the previous 5 to 6 years, potentially indicating that they no longer required CF care. And for a small number, despite passing all of our pretty rigorous QC and identity checks, the genotype that was reported to the CFF patient registry was discordant than the genotype that we had found in our whole genome sequencing study, and we just couldn't do anything further to confirm or rule out a sample swap or reporting error or something like that. And then lastly, 2 individuals actually did have their diagnosis changed within the CF registry to something other than CF. So let's go back to this schematic and talk about these people who did actually have their diagnosis confirmed, this group of 6 right here. I want to reiterate that this number is 6. It was only 6 of 49, or just 12%, that we confirmed to actually appear to have CF based on the data available to us. And really just 4 people out of the entire whole genome sequencing cohort with presumed CF that were left without a complete CFTR genotype after comprehensive testing. And so if I so to say, our ability to detect disease-causing CFTR variants in individuals with CF is very, very good. There are not many that are left without a complete genotype. All right, so tuck that away for a minute. That's the retrospective side. Now we're going to look prospectively and see how full gene sequencing plays out. For this group, we used a different cohort, so I'll take a minute and explain this. This time it was from the CFF-sponsored initiative of the Mutation Analysis Program, or MAP. This provides free clinical testing to individuals with CF who have fewer than 2 CF-causing variants documented. And importantly, prior to February 2021, MAP performed typical clinical sequencing with del-dup, so coding and flanking region, and del-dup analysis. But in February 2021, MAP started performing full gene CFTR sequencing that includes all of the intronic regions. And so this set up a really nice study. So the cohort of people for this prospective study included 40 individuals who already had typical clinical sequencing done and who had fewer than 2 variants identified, fewer than 2 disease-causing variants identified. Full gene sequencing was then performed by MAP to try to answer the question of, essentially, how much more does that get you? How much more does that additional intronic sequencing get you when it comes to detection of both disease-causing variants? So I'll walk you through this flowchart to answer that question. And as I said, here are our 40 individuals who already had typical clinical testing, the kind that many of you probably order. 20 people had 1 variant identified by that testing. 20 people had 0 variants identified by that testing. And I'll note that these are unrelated patients who were randomly selected. So then MAP did full gene CFTR sequencing, includes all of the intronic regions. And in that first group with 1 identified disease-causing variant, an additional variant was found in 9 of the 20 people, so about 45%. But in the group that came in with no variants identified, the intronic sequencing didn't help. And so it did not improve detection rate in this group. Nobody had any variants identified that might explain CF disease. So for the people that actually did have something found, let me just show you what it was. The specific variants that are listed in this table are less important. You don't need to memorize all these numbers. But what I wanted to just demonstrate is that the variants shown in the red boxes here are those that are located deep in the intron. And you can only really find them by either whole genome sequencing or full gene CFTR testing. And the ability to find this type of variant is really the main advantage of this technology. For these 2 variants in the blue box here, you'll notice that they're actually not in CFTR. So they're in CCDC40 and DNAH9. These are genes that are known to cause primary ciliary dyskinesia, or PCD, which of course has some phenotypic overlap with CF. I actually thought this was very interesting, but it got less interesting when we realized these were only found in heterozygosity, just 1 variant in 2 different people. And we had whole genome sequencing, so we took a really deep dive into these 2 genes to see if we could find the second variant in both of these people, as PCD is recessive, and we couldn't. And so this still doesn't explain their disease either, but it was interesting. At least I thought it was interesting. So what did we learn from all of this? Well, as I've said before, nearly all individuals with CF will have both disease-causing variants identified by typical clinical sequencing and del-dup that most of you are probably already using on a regular basis. But we did learn that full gene CFTR testing can be beneficial for some people. Only an exceedingly small number of those with CF, or at least what looks like clinical CF, will not have both variants identified. And there are lots of other potential explanations for what's going on with these patients. So, in genetics, we like to come up with all these plausible, if not exceedingly rare things that could be going on. But these individuals could be symptomatic CF carriers. There might be genetic heterogeneity going on, so actually defects in a different gene. Now, we didn't really explain anybody with genetic heterogeneity in our study, but certainly that exists in the world as a possibility, and that's when we think about ENAC testing and carbonic anhydrase and things like that. There could be epigenetic explanations where you're not changing the sequence of CFTR, but there's other things going on like methylation, chromatone alterations. Mosaicism, this has been reported, I think, once in CF where some tissues have 2 variants and others don't. And we looked at blood samples here. These individuals could be phenocopies, so clinical features that look a whole lot like CF but have non-genetic causes. And then lastly, analysis pipeline evolution, right? So our ability to interpret the variants we find depends a little bit on the pipeline that we use to pull them out of all that sequence data. And we think we're pretty good at that, but things change over time, and so it's possible that we could change the pipeline to pull these variants out of the sequence data, and maybe that would identify something we didn't previously see. But so practically speaking, how does that help the clinicians in the room? So I think the number one take-home point that I have from this is that if you have a patient with fewer than 2 CF-causing variants after your typical clinical testing, the first thing you really should do is look at their phenotype and just make sure that it really fits CF. Now, if you've done that and you've got somebody who you really think has CF and they have one identified CF-causing variant, this is the group that might benefit the most from full gene CFTR testing. And in the US, MAP performs that. I don't know the status of it in other countries. But if you've got a person that you think has CF, but they have no CFTR variants after just coding region sequencing and del-dup, this group is really unlikely to benefit. We didn't solve anybody like this in the whole genome study. MAP didn't solve any. Now, granted, it was a sample of only 20 people, but none of them had additional variants found. I'll caveat this with if you've got a person who has known or suspected consanguinity or who is from a non-white European population, these conclusions may change a little bit because our cohort happened to be mostly white European ancestry, so could reconsider this test in certain circumstances. And then if you've done all of this and you still have a person who you really think has CF and they just have one identified variant, that's where functional testing of CFTR may come in and could be considered, and that's things like intestinal current measure, nasal epithelial analysis, nasal potential difference. And that might provide some additional insight. So I'll end and just acknowledge the many, many people that worked on these studies, the entire CF Genome Project cohort, and the individuals involved in the mutation analysis program. I'll close there with thank you, and I think we have a few minutes for questions.
Okay, I might start actually. I'm curious about whether you were able to get much phenotypic information on that group with no variants. Because I'm just thinking about things that are probably a little bit more specific to CF than maybe some of those phenocopies or other mechanisms. That might be CBAVD, which would be an interesting one to identify in that group.
Yeah, so it's, we didn't get tons and tons. So for the most part, we had CFF patient registry data, which many of us probably know does not collect a lot of, well, I think they actually can collect CBAVD, but most people don't have that information available in the registry. So we didn't have some of that really granular data. We were mostly looking at sweat chloride data, whether somebody was taking pancreatic enzymes, and if they had recorded FEV1s that showed lung disease. Yeah, so it was somewhat limited.
Any other questions anybody has? Carlo?
You suggest a question of tests at the end in these cases, and at the very end, if you don't find anything with your tests, you go for ICM or MPD. And I realize that MPD and ICM are not available in Los Angeles, so we talk about that a lot, but shouldn't that be earlier?
Yeah, you could, yeah, so the question is, I sort of went through, here's all the genetic stuff you can do, and at the very end I said, well, now you could consider CFTR functional testing, and Carlo's question is, maybe you should do that sooner up the line, and yes, I think it's a fair point. Yeah, it's not widely available everywhere, so if you do have it available, you could consider that sooner, especially if intronic sequencing is not widely available, which it is not for a lot of people. Yeah, so that's a really fair point. Yeah.
When we order from the labs, what can you tell us we are having?
Okay, so the question, that's an excellent question. The question is, when we order typical testing from a lab, what are we getting? And for the most part, now this will vary lab to lab, of course, you got to read the fine print, but for the most part, if you are ordering full CFTR sequencing and del-dup, for the most part, that is the coding region, a little bit of the flanking intronic region, and del-dup. And it's very confusing because for a long time, we were kind of vacillating between variant panels and full CFTR sequencing. So a lot of labs will actually still say, you're getting full CFTR sequencing, but if you read the report, they'll tell you it's mostly just the coding region and a little bit extra. It's only somewhat recently that we've now moved into, I don't have a better term for it other than maybe full gene or genome-based sequencing of CFTR where you get the introns. But for the most part, a sequencing and deletion duplication test from a typical clinical lab will be coding region and a little bit of the introns.
Karen, can I just ask, just based on your answer there, so a lot of the time we get whole gene sequencing done in labs, but we're not quite sure whether the del-dup option is present. How much does that add in terms of the identification of variants?
Yeah, that's a great question. You know, many of the labs will quote 2 to 3% of people that have a deletion or duplication. I actually think that's pretty high. I think in CFTR2 data would indicate it's maybe 0.5% to 1% of people have a large exon deletion or duplication. But Ed raises a really good point in that some labs will tie in their del-dup analysis with their sequencing, and others require that you either check a separate box or order it separately. So it's always a great idea to just make sure what's actually been done. And if you have questions about that, you can either find your local neighborhood CF genetic counselor, or if you don't have one, and I know many of you don't, call the lab and ask, actually, because many labs have genetic counselors who don't necessarily see patients, but their job is to talk to providers and to answer questions about what testing was done. And, you know, if you have questions like, you know, it says this, and I don't know what that means, people will explain that to you. Yeah.
Question regarding CFTR function testing. Like, I have like a couple of patients with like more than 10 borderline sweat tests, pancreatic insufficiency, nasal polyps, and for me it's kind of CF. But a lot of mutation of no significance, and then also asthma. So it's like I'm trying to get the nasal potential difference, but like nobody does it in the state. They don't want to do it in a pediatric patient. So I don't know if like is there any effort to kind of help people, like, because, you know, having the diagnosis of CF is a different thing, kind of like what resources are there for us to be able to get also the approval from the insurance to pay for that and help the parents to know if they have CF or not.
Yeah, so the question is about, it sounds like maybe specifically in pediatric patients. When you've got somebody who seems to have an equivocal diagnosis, maybe multiple borderline sweats, one defined mutation and maybe either not a second one or a second one that's of unknown significance, and you don't have great access to CFTR functional testing, what's available to help you either make the diagnosis or not, with the understanding that having a CF diagnosis comes with other things and access to things. And I don't know a ton about who's doing nasal potential difference and where that's available. I will say that there are a few research studies that are doing nasal epithelial cell analysis, so primary cell analysis to look at CFTR function. And at least some of them will take kids, not babies typically, but at least kids. Unfortunately, though, there are other clinicians in the room that might be able to answer this better. To me, it sounds like you've exhausted a lot of things. And one of the things that genetic counselors at least are pretty comfortable with is the idea of uncertainty. And it's a really hard place for parents to be. But I think despite all of our technologies, there's going to be some number of people that we just aren't able to definitively define. And maybe that would change in 5 or 10 years, either as the person gets older or we get a little better at this. But I'd be happy to chat with you after and see if we can kind of brainstorm where to go. But it sounds like you're using a lot of resources already, and it's tough.
I think we have time for one more question then.
Yeah.
How do you guys sort whenever we find a mutation, for example, and there's no functional studies? Do you proceed with functional study on that particular mutation? In previous conversations with Dr. Kathy, I think it depends on the number of mutations that you found. And then the other comment is there was a session, I think it was yesterday, where they mentioned better genetic testing of much better accuracy or quality than the nasal potential difference or the ICMs. I would like to think about it.
Yeah, so the first question, I'm sorry, you're going to have to come back up here for a minute. So the first question, help me out. It was functional testing, sorry. So the first question was when we find a variant, how do we get functional testing if it's not previously been done? So we actually, this came up in a session yesterday. To my knowledge, clinicians cannot just order functional testing on CFTR variants. It's just not a thing. There are some labs that do it. Our lab has done it for a number of, Gary Cutting's lab, I say our like I'm actually in the lab. Gary Cutting's lab and various students and techs and junior faculty have done functional testing for variants that are in CFTR2. And as you correctly point out, it does somewhat depend on frequency. So we tend to look at variants that have been seen in multiple people. I know that the CFF labs are doing functional testing on a number of variants, and we expect that that data will become published sometime in the next year, I think. So that will give us additional insight. But yeah, there aren't any sort of a la carte CFTR functional testing available. As for the additional question about beta-adrenergic testing, I'm not an expert, so I'll have to chat with you more. I wasn't in the session where it was discussed.
We actually have a lot of really good questions, which I'll pass on to Karen, but I'd like to thank you, Karen, for an excellent presentation.
Yeah, thank you. So, let me get out of here. I am very pleased to introduce, I guess maybe I'll introduce both of you, our pro-con debate. And I will preface by saying, one, as Ed mentioned, there's going to be a change in the order here. We're going to first hear from Michael Wolshansky, who is a pediatric gastroenterologist at Hadassah Medical Center in Jerusalem. He's going to be arguing the pro on whether we should be thinking about CFTR modulator use in individuals who don't necessarily have CF or have not quite CF. And then we're going to hear from Scott Bell, who's an adult pulmonologist at the Prince Charles Hospital in Queensland, Australia, and he's going to give the con on why we shouldn't maybe think about this. I will just note, we assigned the pro and the con, and so both of these very qualified people could probably argue both sides, but just keep in mind, okay, they may deny that. Just keep in mind that we made the assignments, and so don't hold that against either one of them. And so I'll welcome Michael Wolshansky.
Well, thanks very, very much to the organizers. Exciting session, and kind of following on from a lot of what we just learned now, we'll talk about some more practical things, exactly a lot of the follow-ups. So we were debating whether a patient is almost or not quite CF to treat or not to treat with modulator. So bottom left is Hadassah in Keren, where you can see Chakal's windows. On the right side is where my lab is. So we can do all the functional testing and nasal PDs and ICMs. So you're very welcome to come and do them in Jerusalem. Okay, next. Yeah, right. Okay, that's good. So I haven't got much to talk about for this presentation. So really, my objective is this. So if and I hope not, but if Scott Bell's cousin does have, I hope not, does have recurrent pancreatitis, and if he carries a CFTR mutation, then after my talk, Scott himself will be pushing to prescribe him a CFTR modulator drug. We've got a few minutes now, and it's going to happen. All right, so we'll start from the beginning. So actually, what happened? This is CF, right? Not what we're talking about today. But I was very, very fortunate to be on a panel before ivacaftor was released, and we were asked what tests to do, and it was in a Vertex meeting. And I was one of the people, not the only one, who said, well, let's try fecal elastase before and after ivacaftor. Let's see what happens. Oh, all the lung people said, oh, who cares, We'll add it in. So they added it in. And this is the Kiwi study. This is Jane Davis's study published, 2016. And of course, everyone was talking about the improvement in the lung function. This is figure 5. I said to Jane, figure 5 is the most important figure in this whole article, because what we see here is that in these children with a G551D who received ivacaftor, the elastase significantly improved, which was an unbelievable finding at that time. So we've moved on from there, and this is sort of after a Kiwi, and there are other studies with younger and younger and younger climb, and the arrival, of course, and this is sort of, we put them together in a chapter I'm writing with Zach Sellers, but basically what we see is that there is certainly the younger the age is, that the exocrine function in CF patients, the pancreas does improve. So, and we've seen now later on that in patients with pancreatic sufficiency, and that's been noted, and there's a couple of studies. This is one example of an adult study. All those dots are attacks of pancreatitis, and what happens after the patients received modulator therapy, no attacks at all. And this is just one example. There are plenty of these papers around adults and children. So, and this is just a summary which is published by Dr. Ramsey a few months ago, looking at modulators in the pancreas, estimated acute pancreatitis per 1,000 patient years. Took all the studies together. And what you can see clearly is looking at the PS patients on the left, PI patients on the right. So on modulator, they have much less acute pancreatitis than not on the modulator, 4.65 to 12.93, and even with the PICF. So I think it's really, really clear this fact. So, but of course, in CF again, we know that very interestingly, the milder the mutation, the more likely you are to get pancreatitis, which is kind of the opposite of what you would think. And this is Keith Oy and Peter Dury. I'm going to say what they did. Published the pancreatic insufficiency prevalence score, the measure of severity of specific CFTR mutations. A wonderful article in gastroenterology. We should all read it, because what they've done is they've listed the mutations, severe and moderate and mild, and we see that what happens is that the proportion of patients without pancreatitis seems to be related to whether there is a more severe or more mild mutation. That if you have two mild mutations, you have less chance, and this is very, very significant. It really is worth looking at that. And the hypothesis is really a wonderful hypothesis, because if you look at the degree of pancreatic ductal obstruction against CFTR function, so if you start from the left side with a pancreatic insufficient patient, that there's no risk, or very little risk, I could say today actually, of developing symptomatic pancreatitis, because there just isn't any tissue there. That's very, very understandable. But as you increase the risk of pancreatitis increases with the milder dysfunction you have. So there is a presence of duct, the duct is opening, there is a bit of reserve, and that goes up, that the risk of pancreatitis does increase. Of course, there's still ductal obstruction, but once you get around that corner, the risk lessens when there is sufficient ductal flow, and that will prevent development of obstructive disease necessary for pancreatitis. This is a beautiful model, wonderful article explaining the risk of pancreatitis. And that actually leads in that you're talking about the milder the mutation, the more likely it is. And this is another look at that. We've now left CF. This is Peter Hegyi, who may be here, I don't know, but his group in Hungary have a different idea about what causes pancreatitis. And his group has said that even in non-CF pancreatitis, the CFTR channel sitting on the apical surface of the pancreatic duct does have a say. And his hypothesis is that in pancreatitis you would have there is a problem with bicarbonate flow, and that is caused by CFTR, a mild misfunction. There was decreased pH, decreased washout of enzymes, and if you have a defect or malfunction of CFTR, that is could be the pathomechanism of pancreatitis in a non-CF individual. So what the point is that as I said, the bicarbonate secretion is integral to the pancreas's ability, and this requires this. And also, by the way, I have to mention that in the United States, pancreatitis is one of the leading GI causes of admission to hospital, nothing to do with CF. It just is. It's well up there as far as costs to our medical services are concerned. We can go further with this. There are wonderful basic studies now looking at CFTR in pancreatitis, non-CF pancreatitis. It's a study by Dr. Koh et al., published a few years ago now, that looking at immunohistochemistry of CFTR in pancreatitis. You can see it's normal. There is the normal CFTR in the duct. And he just looked at other biopsies, looking at alcoholic, looking at obstructive, looking at idiopathic pancreatitis. And you can see that there are differences. The CFTR, the immunohistochemistry, is different. And this is just an observation of this. So it just shows that CFTR, in this article, there was maybe not a direct cause, but certainly an observation that there is pathology. And further than that, going back a few years now, if you look at the articles a long time ago by John Conn, who's at this meeting, and he looked at just take a cohort of idiopathic pancreatitis. This was before we had fancy new screening. Not a huge number of mutations were tested here. But you see, this is a group of idiopathic pancreatitis, mutations causing a CFTR, CF and 5T, of course, as well, and it was much more common than not. And here, this is a study from my lab that we've been looking at. Again, patients who are coming to be tested for recurrent pancreatitis. And what we do is this is the genetic screening. We look for all the other mutations, hereditary pancreatitis, PRSS1, SPINK1, CDRC, etc. But look on the right-hand side. You see, these are patients who are very much selected. They are patients who have no other complaint, only recurrent pancreatitis. A lot of these are in and out of hospital. They're many times during the year, and they've had, as I said, they've got many of them have been, and so what we do in my lab is that they all have sweat tests and they have nasal potential differences. Some of them are even positive, and that's another story. Whether they actually fit into the latest definition of CFTR-RD or not, but certainly they do have recurrent pancreatitis, and they do have a mutation, at least one allele. So what can we offer them? So and apart from my lab, there's INSPIRE, which is an international study of pediatric pancreatitis in search of a cure, which involves a lot of children. These are children below the age of 18, again with recurrent pancreatitis. And in this study, which I was also very fortunate to be part of, published a few years ago now, this is the ARP is acute recurrent pancreatitis, CP is chronic pancreatitis, and the odds ratio. And you see that obviously genetics is very important in these children, but amazingly CFTR, a mutation found in CFTR is even more prevalent than PRSS1 or SPINK1. So these are children, symptomatic children. We're very strict about our admission to this study. You have to have above 3 times as normal amylase or lipase and admissions to hospital, etc. So these are sick children who have a CFTR mutation. And just to change organ a little bit, I also deal with the liver. So this is another interesting disorder called primary sclerosing cholangitis. And primary sclerosing cholangitis is a very unpleasant liver disease. It's progressive to transplant, and there's nothing to be offered to these patients, but their cholangiograms, as many of you in the audience know, they look very much like CF as far as their liver is concerned. Again, these are patients who came to my lab. Again, no respiratory issues, no other phenotype of CF at all, and many of them carry CFTR alleles. So the question is whether these are actually contributing to their liver disease or not. And of course, people are banging on my door saying, you know, what we're doing about them. So, and there is some literature now that if we rescue, and this is a mouse study, and this is using some of the modulators which we've heard about today, is that this is the pharmacological rescue of ductal CFTR in pancreas and salivary and acidic glands in mouse models. So this is just, you know, this lab, which is in Stanford, and they just look at a pancreatitis. It's very, very interesting what they're doing. If you look at the top and, oh, oops, no, can you go back? Yeah. So if you go back at the top and the bottom, you can see that the architecture of the pancreas is abnormal in the top left and the bottom left after C18, which is a modulator. The same thing with VX770, which we're more familiar with. There is an improvement in pancreatic structure and function in this model, which is non-CF. So I think so I propose to this House. So after all that CFTR mutations are significant contributors to pancreatitis in these individuals with not quite CF, and I think that the expanded use of CFTR modulators to individuals with CFTR-related disorders will decrease morbidity, it will decrease mortality, it will increase quality of life, decrease health costs. So I really am pressing, let the clinical trials begin. Thank you very much.
Great, thank you, Michael. And now I'll invite Scott Bell to come up to deliver the con.
Okay. No files have been uploaded. They have certainly been uploaded. Start.
Yeah, there we go.
I've got it here.
Do you? Okay. Do you have a IT? Well, let's just plug them in. Michael disabled it?
Yes. Michael, I saw you sneak into
the tactic we didn't see coming.
Have we got the... That's right. I might just duck out and duck home. That's not a great start, is it?
The IT guys.
Thank you. Definitely.
It's already on there, right?
Well, it should be, but when I press it, maybe you'll find it.
Which one?
This one here, it should be, when I've loaded it.
See, it doesn't have it from the speaker. Let's do it old school.
In NACFC. Should be only one there.
Yes.
Excellent.
Great.
Thank you.
Thank you very much. That is a big relief. Firstly, to the organisers, thank you very much for the invitation to participate, and to be able to debate with Michael has been something that I've wanted to do for many years. In fact, he's debated with me as the editor of JCF mercilessly for a number of years. These are my disclosures. So I thought I'd talk a little bit about Michael to start with. I mean, as you've just heard from him, he's obviously a preeminent paediatric gastroenterologist. He was a very close working colleague at JCF when I was the editor for more than a decade. We worked together in multiple roles. And Michael, not only in the editorial board, but in meetings, whether it be these sorts of conferences or otherwise, is known to challenge medical norms. But he's also a good friend. I must say, though, I was quite confused because in Karen's email, she quite clearly said, if you have a specific case from your own experience that you'd like to present, that's fine. But Michael, on the other hand, said in offline emails to me on a number of occasions, I'm going to bring science to this meeting, I'm bringing the literature, and I'm not really bringing a case. So we'll see. So I think it's really important to acknowledge that there's a lot of uncertainty in this space, and many of us were lucky enough to hear the seminar on the symposium on Thursday, which talked about the CFTR-related disorders revisited. And I thought I'd highlight very importantly that Michael was there getting last-minute notes in preparation. I don't think you were nodding off at that point, or just as well you weren't. So I think the real question here is, what is CF? Or rather, what is almost CF? And I want to highlight this paper and led by our esteemed colleague Carlo Castellani, published in JCF earlier this year. And importantly, just to highlight that Michael Wolchansky was actually a member of the working group. So I think that's an important thing to consider as we go through the evidence. And I think a lot of the discussion should be for this debate around what are we talking about? Who are these people? Thanks, Carlo, for reminding us that these are people, not patients. And you know, this is the latest definitions of CFTR-related disorder, which includes one of three options: evidence of CFTR dysfunction in vivo or ex vivo in at least two different CFTR functional test types, or secondly, one CFTR variant known to reduce CFTR function and evidence of CFTR function either in vivo, sweat chloride being one, or ex vivo in at least two functional test types. Or thirdly, two CFTR variants known to reduce CFTR function, of which at least one is known to be CF disease causing. In a follow-up paper also published in JCF, also with Michael as an author on this occasion, really demonstrates the challenge we have here. And that is that if we, for instance, look at the clinical row, you can see that basically people with almost but not quite CF range from CFTR function from around 10% right up to 50%, as you can see with the white bars. And similarly, within that group, if we look now at the genetic row, you can see two particular variants, one very close to Michael's heart, the D1252H, which he showed in a few of his slides, but also the R117H and the poly-T accompanying intron variants, which he also mentioned in his slides. And as you can see, there's a great variation. So I think the hub of the question here is, who are we talking about? And who are those people that have CF, and who are the people have almost CF but not quite? So another question we might like to pose here is, where does one draw the line So let's assume that patients with CFTR function at epithelial surface level is around 20%. You can see, as you walk through down the slide, that this could include patients with CFTR-related disorder. It definitely includes patients with a disease-causing mutation on one allele and a variant of varying clinical consequences on the other allele, such as the R117H poly-T allele, possibly also the D1252H variant. And as you can also see in terms of the sweat biomarker, these patients often have quite non-diagnostic sweat chlorides. As highlighted here in his recent work, there is some challenges, and I think this was clearly demonstrated in the symposium on Thursday, in how we might actually pin down who this group of people are. And I want to draw your attention to Michael's conclusion in this paper, where he highlights, importantly, in the era of CFTR modulators and their potential clinical benefit, it's of utmost importance that we get the diagnosis as much as possible. And I would highlight that much of Michael's argument was based on patients with cystic fibrosis, people with pancreatic sufficiency, rather than patients who have almost got cystic fibrosis. So I think, having thanked Karen for the invitation to participate in this debate, I think largely the reason I got asked to do this was a way of stopping me emailing her every month or so to ask her, what the hell does this mean in terms of a new variant that I'd never heard of? And so thank you very much, Karen, because you have been very helpful in helping us try and decide what's almost CF in our people with that are referred to our clinic. And this is a readout from the most recent disease-causing or otherwise variant list from the CFTR2 database. And as you can see, in the small writing on the top left and in the bottom right, you can see that there are now almost 500 variants that have been annotated, of which 80% or thereabouts, just over 80%, have been allocated to being disease-causing, and around 10% variants with variable clinical consequences. And that's what you'll see if you download this screen here. And so about 10% of those that have been fully annotated are actually thought to be of variable clinical consequences. So now, Michael, I'm not going to be apologetic here. I'm going to talk about a couple of cases because I think they illustrate the point. So the first case is a young woman who was diagnosed by newborn screening and was found to have an F508del variant on one allele and the D1252H variant on the other allele, one of the variants very close to your heart. The sweat chloride performed by the clinicians was 35. And the young woman was actually quite well throughout her childhood, but reviewed in the CF clinic as well as in the local outreach service. And during that time, she did not require hospitalisations. She was pancreatic sufficient with excellent nutritional status. And she was transferred to adult care at the age of 18. At that time, she'd had intermittent sputum samples when she had cough and some sputum production through her adolescence, but she wasn't on any regular CF-related medications. She did get winter bronchitis, probably 2 or 3 times, usually following an viral upper respiratory tract infection, which on each occasion responded to antibiotics. But if she did take the opportunity of not having antibiotics, the cough would persist. As you can see on the right-hand side, following transition, she's got spirometry, which is within the normal range, but at the low end of the normal range, and it's been stable over this 5 years of monitoring. She attends our outreach clinic, and unlike in Israel, our patients have to travel a long way. We would see her twice yearly at the outreach clinic in the hospital that she is closest to her home, 1,000 kilometres away. And we would see her 6 monthly. She would often say to us, look, I'm really not sure I can come to clinic today, and it resonates with some of the earlier discussions. maybe I'll have to miss this clinic because I'm just too busy at work. She also had a long-term relationship, and in the process of talking through her genotype and the fact that she would qualify for triple CFTR modulator therapy in our system, we had a discussion about the pros and cons of that. And her questions, I think, were very important and logical questions. Firstly, where will I be in 10 years if I don't take modulators? Will I get any adverse events from taking them? And if I want to have a pregnancy, what should I do? So again, the CFTR2 database is very helpful in helping discuss these cases with the patient. And this is a readout from the database with the particular mutation variants that she has. And I draw your attention to the fact that some patients with this variant combination have CF and some do not. So let's move on to the next case. It's a remarkably similar case of a patient, woman born in 18 years ago, and her diagnosis, her genetic testing revealed an F508del and an R1178 mutation. Remarkably similar sweat electrolytes of 35. She had a remarkably similar clinical situation, and she also was really worried about coming to clinic on a regular basis because really my lung function is very stable, and apart from taking antibiotics 2 or 3 times a year, I'm very well. During the first couple of years of seeing her in the outreach clinic, we also worked her up for the polythymidine variant testing, and she was found to have the R117H on a background of 70. She asked the same sort of questions. Where will I be in 10 years if I don't take it, compared to where will I be if I do? Will I get any side effects? And can I take this new drug without any problems in pregnancy? Again, from the CFTR2 database, one can see that this combination is either associated with cystic fibrosis in some people, and some people don't. So let's talk about cystic fibrosis screen-positive infants with an inconclusive diagnosis. So what this slide demonstrates on the left, and this is from Tanya Gonska, who presented on Thursday, demonstrates that the initial sweat chloride is a really good indicator or predictor of whether one will develop cystic fibrosis at the age of 6, compared to those that had a low and non-diagnostic sweat chloride. But importantly, at the age of 6, pulmonary function and nutritional status in those with CF SPID is normal. My close colleague John Massey did this work several years ago and similarly demonstrated the relationship between sweat electrolytes and whether one had, with an R117H mutation, had 5 thymidine versus 7. And as you can see, the range of sweat electrolytes is much greater and to the right in those with the 7T variant of R117H. I'd remind you that the CONDUCT study, which was a 24-week randomised controlled trial published in Lancet Respiratory in 2015, looked at patients with the R117H mutation treated with ivacaftor. The primary endpoint did not show a significant improvement in the FEV1% predicted. As we always do when you get a negative result, the investigators then drilled down and demonstrated that actually the older patients with established disease actually had improved spirometry, sweat chloride, and markers of quality of life. If you were doing this study again today, one would ensure that patients recruited to the study, we would know their poly-T status. That wasn't known. But one could imagine that it was actually the patients with 5T that were the ones that responded to ivacaftor versus those with 7T that did not. To address this question, your colleague, when working in Belfast, addressed this question and really wanted to ask the question, what actually happens over time to those patients with the R117H mutation? And Northern Ireland has the highest rates of the R117H variant in the world. And as you can see in the table to the bottom right, those patients with the R117H on a 5T background had a rate of reduction of 0.6% predicted loss in lung function per year, compared to those with 7T, which were very stable. As demonstrated here, the green line demonstrates change over time in those with a background of 7T versus the black line, which shows a significant reduction over time. So it really is important to understand the interface between the genetics and the clinical phenotype. So let's think about our two young patients who are considering whether they should, because in terms of the government rules in our country, they qualify for Trikafta. But do they have cystic fibrosis? Mild lung disease, imaging pretty normal, normal lung function, stable over time. I'd like the audience to consider what happens when we trial medications. And this is a post-marketing approval of almost 500 medicines. And what it demonstrated was, after pivotal clinical trials, withdrawal of drugs is not uncommon. Hepatotoxicity, noting, Michael, as you did, liver dysfunction is very common in people with cystic fibrosis, is common. But perhaps more importantly, what happens when we actually prescribe drugs off license? This study demonstrates that the cumulative risk of adverse drug reactions is 50% higher in patients receiving drugs off-label compared to those that are treated with drugs on-label. We know that CFTR modulators, at least at the current time, are very expensive therapies. We also know that rates of cystic fibrosis are very much underdiagnosed. And while the numbers of people with cystic fibrosis are low and the rates per million of the population are likely to be much lower, when you correct for the size of the population, for instance, in parts of Africa and also in the Indian subcontinent, there are many people around the world with cystic fibrosis who are as yet not diagnosed. This is a map of GDP around the world, and as you can see, the bluer colours are the higher GDP. The GDP in Israel and Australia is not dissimilar and about mid-range. But you can also see the areas where there are many undiagnosed people with cystic fibrosis, where GDP is low. And similarly, where the amount of dollars spent on health is much lower. And here we are, just to remind you the sort of dollar value that we're talking about per patient per year. And one needs to consider that in the light of people with very minor symptoms who actually we don't have a good idea of where they will be in 2 decades' time. And finally, I'd just like to highlight another paper of Michael's published in Lancet Respiratory, where he actually deals with this exact problem of the treatment of people with cystic fibrosis in low and middle income countries. And I want to read this out to you because I think, Michael, this probably makes the case. Optimisation of cystic fibrosis healthcare delivery in resource-poor countries should not be taken as absolving countries with adequate healthcare resources, which most of us come from assisting countries whose access to cystic fibrosis care is restricted by economic or other challenges. Breakthrough pharmacological treatments, such as CFTR modulators, can cost more than $300,000 per year per patient, making these drugs inaccessible for people living in that's quite an emotive word, Michael, impoverished countries. So I would make the case to the audience that almost but not quite CF, really we shouldn't be treating those patients with CFTR modulators. We're still struggling to even understand what almost CF is, and I'm not even sure that in the average clinic, as Dr. Chowdhury highlighted in his debate on Thursday, is actually achievable for many patients. Most patients, or people, Carlo, will do very well. But we need more information. We need to study this group of patients. We need to understand their longitudinal outcomes. But in the meantime, let's be responsible here and not necessarily expose our patients to drugs where they're not indicated, and also to consider the global need and how we can do the delivery of modulators in a fiscally responsible manner. Thank you very much.
Thank you, Scott, for a wonderful counter-argument. And now I invite Michael up for a brief rebuttal.
I haven't got my pictures of Scott. I've got them at home, and I couldn't send them here because they're. At least I was in the lecture, you know. I won't tell you where he was. He's a big baseball fan. He was there at the game. Okay, so you know, Scott, you missed the point. You know, I mean, thanks for looking at my CV, and I'm very happy to have been part of Carlo's CFTR RD, which is an academic discussion as to where we draw lines and what associated disorders with CFTR, etc., etc. That's fine, but we're dealing with people. And the title of this was almost or not quite CF, not CFTR RD. I don't want to treat all patients with CFTR RD. Of course not. We're dealing with people who, unlike those two ladies who you presented, going through life without any issue, we're dealing with patients who are in hospital 5, 6, 7, 8 times a year with possibly a CFTR-related problem. And my question was that we need to do, I agree, we don't need to treat them, I don't know. We need to do trials, we need to do studies, we need to take these people and see what happens. That is my question.
So I think the two key issues here are what are we talking about? Where does CF start and where does it finish? And I think that's unfinished business. I think the two symposia have clearly demonstrated the challenges, both in terms of the extra tests and the delivery of those, but also in terms of rolling these variant analysis out into newborn screening. So I think that's a real challenge, and I don't think we need to know. I think we need to know, and we don't know at the moment. And what we do need to do is monitor this cohort of patients over the years. What I think's challenging, though, and you raised this question before, or your comment before, Ed, is are people with CF-related disorder and CF-SPID in registries? Yes, but not completely, and there's several reasons for that. Some people philosophically in CF who are delivering CF care don't put them in the registry because they don't believe they have CF, but others do because they want to capture it. And then, of course, there's all of the people who actually are not cared for in CF centres. So I think we do need to advocate for the inclusion and adjusting our registries to support being able to monitor this cohort of people. But we also need to be clear about how we're going to do that and who we're going to do that on. So thanks very much. And I certainly think we need to be very cautious in giving people who have got a very benign course drugs which we've really monitored for up to 10 years. We don't know the long-term impact. Thank you.
So great. Thank you for really an excellent debate and very thought-provoking. I just maybe one or two questions. I'm curious, Scott, what did you decide to do with the two patients you presented? And how would you counsel them if you are going to treat them? What benefits do you think they'll get?
So we had an open discussion. We looked at the lung function over time, and at this point in time, we said, let's keep that card up our sleeve, and we'll use modulators if the clinical situation changes. Because some people with that both those genetic backgrounds do develop CF or do have, advancing cystic fibrosis-related symptoms, which may require treatment, but not yet.
Okay. And then, Michael, how would you design a trial to look at CFTR modulation in your pancreatic patients, or pancreatitis patients?
So get 100 patients with recurrent pancreatitis carrying a CF allele who are in hospital more than 5 times a year, more than 5 attacks a year. To give them a modulator. I don't know whether it's what type. We talked about whether it's single, double, triple therapy. I don't know. That can be discussed. And over time to see whether the attacks of pancreatitis and the admissions to hospital is improved.
So my final question is really for the audience, and I'd like to thank them for an excellent debate. So I have 3 questions. The first one is, and we can raise our hands here, is who thinks that most patients with 1 or 2 CFTR causing alleles and a borderline sweat test between 30 and 60, that we should be treating most of those patients with CFTR modulation? Any hands? Oh, okay, that's interesting. So more information. Well, that's my third question, actually, okay? And then, the next question I think you've already answered for me. So do we think we should be treating patients with CRMS with CFTR modulation at this point in time? That's a flat line. And the final question was, do we need clinical trials to look at this population and look at CFTR modulation? There we go. And I think that's the outcome we were hoping for. So with that, I would like to thank everybody for participation in this workshop. Our fantastic speakers, my co-chair, Karen Rowley, as well. Thank you very much.